So this is what the peripheral artery catheter would look like. So again, it looks just kind of like a basic IV, but we know that you're not going to be able to measure blood pressure with an IV. So if you look up at the monitor and you see your standard tracing, your standard so you see something like this on the monitor, then the baby has to have either a UAC or a PAC. So now, because of their tiny little vessels, they've got to have some help usually with getting this catheter inserted. So they use either like a vein finder, or they'll just use a transilluminator and just shine the light, and you see how transparent the skin is. I mean, they have pretty much no musculature and no extra adipose tissue yet to kind of get in the way of these vessels. And so that's kind of like their go-to is to just use some kind of illumination device, and then they'll stand a much better chance of getting the catheter inserted into, say, like the radial artery. So now this example here where they're using like a vein finder, they're looking to see like if they can get an IV access, but just pretend that this was underneath the wrist, because that's where they would be shining the light, is right underneath the wrist, to try to look for that radial artery. Okay. So for the PAC, or peripheral artery catheter, we know that you can use it for a newborn, or you can use it for an older pediatric patient. And the way that the physician would insert this, it just depends on their preference, and I guess the most beneficial at the time. So they could do what's called a percutaneous, or use like a scalpel and do a cut down type of procedure to get the catheter inserted. And in most cases, they're probably just going to do the percutaneous, where you just literally just start with your catheter and then puncture the vessel, and then thread the catheter into the vessel that way. The modified Allen's test, we know that's not going to really be possible for a newborn, because they're not going to be able to follow your instructions. But like with an older patient, for sure, you're going to get them to follow the same process as far as making the fist, and then slowly releasing the fist, and et cetera. And then again, that transilluminator, that same transilluminator that you could use to detect if there's maybe a pneumothorax, you could double it as a vein finder or a vessel finder, and just kind of go that route to have a better chance of getting the vessel catheterized. Now, when one of these catheters is inserted, there's still going to be the same type of setup where you've got to have a pressure bag, and of course the IV tubing itself, it has to be very like non-compliant so it doesn't stretch. And then you've got your three-way stopcock that's going to help to ensure that the blood is going in the direction that you need it to go at whatever particular time. So again, with the smaller babies, their PACs are not really going to look anything like this, but it will be pretty close. Again, you're still going to need to have a pressure bag, and you still have to have IV tubing. But if they're going to have a three-way stopcock in their system, it depends on the system that they're using. The ones I always saw did not have a three-way stopcock at all. But again, there's another brand that may use a small three-way stopcock, and we just know that wherever you're pointing that stopcock is going to be the off direction. So now, complications, not much different from when we were talking about complications with the capillary blood gas sampling. So it's always the same things that we're concerned about: infection. So they try to keep these catheters in as short of a period of time. So we need them to help monitor and get the blood samples and things like that. But we know that the longer they're in, the more likely that they can become infected. And then, of course, clots and hemorrhaging. And if you get air into one of these lines, then that air bubble can lead to an embolus. And in fact, taking blood from a UAC, that's a whole nother process. I mean, compared to just a regular arterial catheter, when you're taking blood from that, this UAC is a little bit different in some cases. And of course, you'd have to have the guidance and the training. And you'd have to get checked off on being able to take blood samples from the UAC, especially depending on the type that your facility might be using. Now, complications for UAC specifically. It says here intraventricular hemorrhaging, and this isn't necessarily the catheter itself causing the brain bleed. It's the anticoagulants. If you got someone who's very premature, they're already at risk of having brain bleeds or intraventricular hemorrhaging. And when you couple that with the fact that you've got a UAC and it's going to require like a continuous infusion of some kind of anticoagulant, then that could just double their chances of having a substantial brain bleed. And then because of the way that these catheters are positioned, you're inserting them into the into the umbilical artery, which means that in that area, you could alter the blood flow. So the mesenteric blood flow right around the gut area could be affected. And then neck is just a really bad infection. And this is more along the lines of maybe you weren't using the cleanest technique to insert it, or once the catheter was inside, what if it nicked something? What if it nicked the bowels or something like that? Then that can introduce an infection as well. So it's just there's just a lot of risk factors involved with these. But once they are inserted and everything is working the way it should, you and the patient get the benefit of having that real-time information like blood pressure and access for meds and for the UVC and for the UAC, multiple blood draws if you need to. Now, here's something that this isn't brand new technology. It's been around for a while, but have hospitals really bought onto it or they really bought into it? I don't know. The first place I worked, it was a teaching facility, and they were always like jumping on whatever was out there to see how it worked and to see if it would really work out for the facility. And this is something that could give you the benefit of not having to always take a blood sample and run it through the analyzer. Because with a continuous blood gas monitoring system, as long as you have an arterial catheter in place, you can connect this little device in line with it. And what it will do is it will take a little bit of blood and pull it into the analyzer, run an ABG on it, and then it'll display the results for you on the screen. And then it'll, of course, the blood will just be given right back to the patient. So then that means that instead of you having to always go and take the blood from the catheter and run it into the analyzer or send it to the lab to have it analyzed, this is just doing it for you right there. And you can set it to do it every hour or every couple of hours or every 30 minutes or however many minutes you need to just get an ABG on your patient. So with something like this, it would seem like every hospital would want to buy one of these and have it so that you don't have to be always taking a blood sample and running it through the analyzer. But these are not trouble. I mean, they're not like foolproof. There's always something going on with them. It may be a little bit off at times, and which means that you still will have to get a blood sample yourself and run it through your own analyzer or send it to the lab. And then that way, now you can compare, like, this is what we got, and this is what the machine is measuring. And you could see the discrepancy sometimes. But when they work pretty well, they work pretty well. Your central venous catheter. So again, nothing really to say about a CV catheter, except for the fact that it's all about right side of heart. And we know with the CVP, normal CVP, depending on where the tip of the catheter is inserted, should be about 2 to 7. And again, with babies, it's the same thing. It's not a brand new set of normals or these hemodynamic parameters that we would have to memorize the same for the adults. And then let's say that this is a newborn with a UVC or umbilical vein catheter. So they've got this UVC connected to a transducer, and then on the monitor, you're seeing CVP. And then what else is that UVC going to be capable of doing? Again, giving IV fluids, giving nutrition. So this is, of course, total parenteral nutrition. And then when we think about like older kids, a central catheter, which would be considered to be a PICC line. They can be discharged home with one of these. And then also in general, if your patient has a central venous catheter, no matter the type, whether it's a UVC with a newborn or just a regular central catheter with an older child, then the early goal directed therapies, that just means that if you know that there is septic shock that's now that's now developed in the patient, one of the main things that we're going to need to do in septic shock is to try to get the volume back up. So we're going to try to get the blood pressure back up. And to do that, you're going to need to consider giving some vasopressors, you know, your dopamine, your norepinephrine, and et cetera, whatever you need to do to get that blood pressure back up. And with any kind of vasopressor therapy, it's highly, highly, highly recommended that you give these vasopressors through a central catheter. Will a normal little peripheral IV work? It could, but you're going to need to titrate those pressors like regularly. And sometimes you need to give them a little bit faster. So you need a bigger catheter that can handle that. So that's always the goal. It's like, if you got someone who's that hemodynamically unstable, you want to be thinking central catheter. And also, you want to be thinking arterial catheter so that you can monitor the blood pressure and see how it's changing instantly. So same complications when it comes to any type of catheter. If you leave it in for too long, you can run the risk of some kind of infection. And if air gets into the line, then that could be, of course, not good. Inserting the catheter. while you're inserting it, sometimes that could lead to some arrhythmias. And then depending on where you insert the catheter, like say if you inserted it into the internal jugular vein, then while you're inserting the catheter, you have to start off with a needle. You have to puncture the vessel first. And while you're puncturing the vessel, then you could accidentally maybe puncture the trachea as well. When they do this usually with some kind of visual, they have to have some type of like ultrasound or fluoroscopy or something. That way they can see exactly where they are and what's going on. So you just want to insert one of these things blindly. But these are still some of the potential complications as we see here. Now, pulmonary artery catheter. Now, if you use something like this, you must really have someone who's very hemodynamically unstable, or someone who you really need to stay ahead as much as possible on their changing hemodynamic status. Now, the last bullet point says that a pulmonary artery catheter is going to be useful in helping you to see what's going on with the left side of the heart. But just remember that the PAC can also measure CVP. It can measure what's going on the right side of the system as well. So not just PCWP cardiac output, but also PAP and RAP or CVP. And then this is just to show you just the main ports again when you have a pulmonary artery catheter in place. So if they chose to insert one of these into the patient, then this is usually the standard of what you would expect to see. This catheter, as you see, is versatile. You could do like the regular thermodilution method where you're using cool saline and you're injecting it into the proximal port of the catheter to measure the cardiac output. Or you could just have it doing like a continuous measurement of cardiac output using like the heating element or the heating filament. So you got two connections depending on what your plans are for this catheter. But both of them are considered to be the thermistor connections. And then the distal port, and these are of course labeled, they'll be stamped to say PA distal. And these, of course, are all connected to IV tubing with a stopcock. So that way you'll know if I need to take blood from the pulmonary artery, the distal pulmonary artery port, then this is where I need to get it. So that way I can get a true mixed venous PVO2. And also, this is where the SVO2 is being measured. And to measure SVO2, you have to have this little connection. This goes into the device, the monitor. And then that way, now on the screen, you'll get your SVO2, which we say normally should be about somewhere around 75%. And then that proximal port is usually where they would connect the pressure transducer so that way you can measure your CVP. And then also, this is where usually your IV fluids are going to go, or any other meds that need to be infused pretty rapidly will go through that proximal port. And then also for just plain old labs, if they need to run labs, just basic labs, and all you need is just venous blood, then you'll just get it from your proximal port here. And then finally, the balloon port, there's going to be a syringe connected that's limited to 2.5 milliliters. You can only pull it back to 2.5. And then that way you could inflate your balloon anytime that you're ready to measure your PCWP or pulmonary capillary wedge pressure. And then as far as the procedure itself, this is nothing different from the adult. So as they're inserting one of these catheters, they got to be keeping a close eye on the monitor. So they'll insert it, and then once it gets into the right atrium, they would see the tracing that looks to be what normal CVP should be because you're in the right atrium. So somewhere around 2 to 7. And then they'll inflate the balloon and continue to advance the catheter. And then the next change that it should see is the amount of pressures will go up to about 25 over 0 or about 30 over 0, which will reflect the pressure inside of the right atrium. And then as they continue to advance the catheter, they'll now see a systolic and a true diastolic measurement. So this will be your classic pulmonary artery pressure waveform, where you've got about 25 for the systolic and somewhere around about 8 or 10 for the diastolic. And then as they continue to advance the catheter, the balloon is still inflated. At some point, the balloon will get stuck or wedged into the pulmonary capillaries. So whichever direction it took, whether it went into the right pulmonary trunk or the left pulmonary artery trunk, it won't matter because at some point it's going to get stuck. And when it gets stuck, the tip of the catheter is now going to only measure the left side of the system, which will be our PCWP, or pulmonary capillary wedge pressure. So A, B, C, and D is just what they're looking for on the monitor as they're inserting it to make sure they're in the right place and that the catheter hasn't gotten stuck somewhere, like gets stuck in the right ventricle and just kind of winds or just wraps around itself or coils around itself. And if that happens, as they keep pushing and they keep seeing this, then they know that the catheter's not going into the pulmonary artery like it's supposed to. Have to pull it back and deflate the balloon and try again. And then this right here just kind of shows us an overview of these 4 different waveforms here. So starting off in the right atrium and then eventually the right ventricle. And then your PAP will be measured. And then the wedge. Now, of course, once that catheter is in the right ventricle, what if it touches the vessel? Or what if it touches not the vessel? What if it touches the wall of the ventricle? If it does that, then the heart is going to respond because there's something foreign on the inside of the heart that's now touching the wall of the myocardium. So then that's when they could definitely see like PVCs happening. You have to be prepared. So in other words, no one is going to attempt to insert one of these catheters at the bedside unless the crash cart is right there, ready to go, in case they have to jump right into like a CPR kind of a situation. That's for like, of course, with older kids. With the younger, like the neonates, it's going to be you got to be prepared for NRP. For the older kids, you got to be prepared for PALS. Now, and then this right here, what do you expect to get as far as ABG results? You expect right after birth, they got a transition still. Their pH is usually a little bit acidic. So that's expected. So if you get an ABG on a brand new born baby, don't expect it to look normal until a few hours have passed at least. So then once they do transition and they completely get settled into their new environment on the outside, then you should see the pH be somewhere closer to around 7.40. And then the CO2, as you see, anywhere from about 30 to 40, and then the PO2 normal, and then bicarb is going to be somewhere else. It's going to be on the acidic side. Over on the right, I included, because they didn't include this in the chapter, and they really should have, because this is something that is happening all the time, where they would send a sample of the umbilical cord gas, or I'm sorry, the umbilical cord blood. So that way you can run a blood gas on it. And they'll usually send you both. They'll send you blood from the vein, and then they'll also send you blood in a separate syringe from one of the arteries. And so what this does is it gives the physician a chance to see what was going on before the baby was born, meaning like, was the baby really, really in trouble as far as hypoxia? Because if the baby was hypoxic before birth, then there was a lot of anaerobic metabolism that was happening, which would mean like more of an acidic pH. So sometimes they use this 20, 30, 40, 50 rule to kind of like guesstimate what the PO2 and the PCO2 should be, depending on whether it's the artery or the vein. So as we see, the artery, the PO2 should be somewhere around 20. Because that was the blood that was returning back from the fetus headed to the placenta. And then, of course, the PO2 in that vein should be a little bit higher. Somewhere around 30 is what you expect to be normal for PO2 that's being transported into the fetus. And then for CO2, 40 and about 50. So then this cord gas, there's something that they call clot catchers that you'll have to ensure that you place onto the syringe, because in most cases, when they take the blood from the cord, they don't use a real ABG syringe that's already prepared with the heparin inside of it. They'll just use like a regular old syringe that has no heparin, and then they'll send this blood to you and want you to run a blood gas on it or on them. So then, luckily, manufacturers make what's called clot catchers, and all they are like little filters that will be inserted on the end of the syringe, and then you insert that into the analyzer. So that way, when you inject the blood, any clots, and there are probably going to be a lot of clots, if that wasn't a heparinized syringe, will get caught in the clot catcher, and then you'll possibly save your analyzer from having some maintenance problems because of blood clots. Now, I was always pleasantly surprised when they sent me a sample to run, and it was a real ABG syringe. And I think what happened was somebody in our department was making sure that they always had ABG kits, like the anesthesiologist will always have kits available, or whoever was getting the sample, whether it was the anesthesiologist was getting it, or the OB, or even like the nurse, the circulating nurse, or whoever was doing the sampling, they would always know to get an ABG kit. And that way, that would minimize the chances of a major clot getting stuck in the analyzer. But even still, we would still use the clot catchers, even on the ones that came up in an official ABG syringe. Okay, and then just for perspective, how do they know which vessel is which? Then, of course, obviously, the biggest one in that cord has to be the vein. And the smaller ones are going to be the arteries. Now, so here are the questions that we have for this chapter. So after you collect a sample, and this could be any kind of blood sample that you're trying to do a blood gas on, which one of these situations could cause your pH to be abnormally low? Yeah, so if you were doing a heel stick and you were squeezing on that heel too hard, then now you're introducing all this other fluid, usually like lymph material, with your blood, and then that could cause your pH to become more acidic than it should be. Which vessel would you consider? for a preemie. Dorsalis pedis. Now you could, but now remember, with them, I didn't go into the information here, but when you think about the sizes of the vessels in relation to each other, for a preemie, their temporal artery is huge. I mean, it's usually even bigger than their radial artery. So that just means that you have a much better chance of getting blood from the temporal artery or using a catheter there compared to, say, like a dorsalis pedis or even like a radial artery. And which artery in the lower extremities will be manipulated the same way that you would do your ulnar artery? Yeah, so it's going to be C. It's going to be that posterior tibial. So that would be almost in essence like your ulnar artery would be when you're checking for your Allen's test or collateral circulation on the arm. Accuracy of a CBG. Hypertension, right? There's not enough blood volume or the pressure isn't enough, then for sure you may end up getting inaccurate results if you do get blood. And is this true or false? All right, this is false. No, just stay away from the curvature because you could cause some problems with that bone. You could actually have, as they were saying in the reading, you can end up with like an infection in the bone. So just stay on the sides. CVP can be affected by, so which one of these would not affect your CVP? Right, so left ventricular pressure is not necessarily going to affect your CVP. CVP is right side. So all these other things could, like the overall volume, like if you're dehydrated, then you're going to have a lower CVP. Myocardial function, that's generic, but we could specify, say, right side heart failure. That could lead to an elevated CVP. And then systemic venous return, this is again fluid status. If you've got way more coming back to the right side of the heart than normal because there's more volume, that's going to make your CVP higher. But again, your left ventricular pressure is not going to affect your CVP. Okay, so that's the blood gas chapter.